Hello, my name is Shriya Garg. I am a rising junior at the University of Georgia, double majoring in genetics and economics, and I'm with Dr. D.
Hi again. Thank you, Cecilia, for having us. My name's Chris. I am a radiation oncology resident at Memorial Sloan Kettering Cancer Center, and I'm privileged to be principal investigator for Disparities in Global Oncology Group in the US and globally.
Yes. Thank you so much for having us. I'd love to talk a little bit more about what inspired us to research this topic, specifically with the disparities in palliative intended treatment for disaggregated Hispanic populations. I think one of the main reasons that we chose this topic was our group primarily focuses on disaggregated Asian and Asian American cancer patients. And one of the big databases that we use is the National Cancer Database. And so while we were kind of doing those other analyses, we did find that there was a lot of data for disaggregated Hispanic populations. And after doing a literature review and finding that there wasn't a lot of studies focused on Hispanic groups or disaggregated Hispanic groups, we did really want to focus and see if there were disparities in Hispanic subgroups. And I think it was also very interesting for us because in the past, I know that the group has published research about the disparities in Asian American cancer patients. And so we were very interested to see if the same kind of disparities within subgroups were present for Hispanic populations as well. And so very happy to be a part of this amazing work.
Yeah, absolutely. I think I just want to highlight that so much of prior research in cancer and throughout medicine has really aggregated very diverse groups of patients, whether Asian Americans, Native Hawaiians and Pacific Islanders, or Hispanic patients. And these are really diverse, broad groups with pretty disparate and diverse immigration histories, collective histories that are often aggregated in one big monolith. And our group seeks to push back against that a little bit and highlight how are these groups different from each other? What are some subgroups whose disparities in access to care may be overlooked when we look with a better magnifying glass? And this slice of the pie, patients with common cancers receiving palliative intent treatment, something that we wanted to explore further.
So in our study, we use data from the National Cancer Database, and our study kind of takes two different ends. And so the first thing that we did was a retrospective cohort analysis, and we focused specifically on patients with stage four metastatic breast, lung, and prostate cancer, and they were diagnosed between 2004 and 2021. And then the second thing that we did is we performed a multivariate logistic regression analysis, and got the adjusted odds ratios, and we controlled for a variety of different variables like age group, facility location, sex, and geographic location, among others as well.
I just want to add that the National Cancer Database is a really powerful database for studying initial treatments and initial diagnostic parameters that patients experience. This is a database that's aggregated by the American College of Surgeons. They actually fund it as well, and the American Cancer Society, I believe. And what they're able to do is actually collect data from about 1,500 Commission on Cancer accredited facilities, which captures about 70% of cancer diagnosis with particularly solid tumor diagnoses in the US. But what's unique about the National Cancer Database is there's pretty impressive disaggregation by different subgroups. To my knowledge, it's one of the few cancer databases, if not the only one, and probably the largest one that has this data. It disaggregates patients based on self-identified not just race, but also kind of country of origin and ethnicity. And I think what it does is really helps to further the discussion surrounding diversity in the US.
Yes, and then also in our study, I didn't mention, but the cancer database that Dr. D is referring to as well specifically has all the different Hispanic subgroups. And so some of the ones that we focused on were patients of Mexican, Puerto Rican, Cuban, South and Central American, and Dominican descent. And then there were some other subgroups as well that may not have been in those categories as well. But that was also great for our study as well.
I think I just want to highlight that there are people who are doing really phenomenal work in the community with a focus on people who are of Hispanic background. Dr. Narges Flores is one of our kind of collaborators and mentors over the years, and she's based at the Dana-Farber, and she spearheads work that looks at lung cancer, particularly amongst younger female patients with lung cancer. And her work is a little bit upstream of kind of the palliative stuff that we study here, but her work really helps to identify what are the unique needs of these populations, both from a psychosocial standpoint, but also from the perspective of biology. Like, are there mutations that are more prevalent in particular subgroups? We know, for example, that people of East Asian descent are more likely to have EGFR-driven lung cancers despite being non-smokers. Are these different in people of Hispanic descent? Dr. Flores has done a phenomenal job kind of pushing that dialogue forward, and she's really an advocate for these diverse populations. There's a physician named Dr. Olazagasti, who's in Florida now, who's also done a phenomenal job with a focus on her work. I actually think in conjunction with Dr. Flores, focusing on people who are of Hispanic background. And I think, having advocates like this who are physicians in important positions of research and administrative kind of roles, you know, play a big role in creating spaces that are able to advocate for patients who may or may not have, barriers in access to care. So I think I just want to kind of shout out work that's been done in the community, and really kind of a lifetime worth of effort that a lot of these people are putting into improving care for patients.
I think one thing that's important to highlight is that there has been a lot of literature that have focused on the disparities in palliative intent treatment along the broad racial, socioeconomic groups. And so our study kind of hoped to go beyond that and look specifically in the Hispanic subgroup and see what disparities look like, or if there were disparities beyond just the broad racial geographic lines that are already drawn. And so that was really interesting for me, just to kind of take one step further and build upon what's already existing in the literature, which was just a formative experience.
I want to highlight the big picture finding, which is the heterogeneity in access to palliative intent treatments that we see across the board. I think part of our hypothesis going in is that the often aggregated Hispanic groups are actually quite heterogeneous in their access to treatment. And I think the fact that we're finding such stark differences really speaks to how these, what are ultimately likely social determinants of health, can influence and play very differential roles for the different Hispanic groups. And I think having a better sense of how these quote unquote outcomes, so these issues of access are different, can speak to mechanisms that may underlie these inequities, and can therefore influence how we can design interventions to improve access in a more equitable manner.
Yeah, so I think that there's a multitude of different strategies that can be implemented, and some of the ones that I'll mention are definitely not the end all be all. These are just kind of jumping points that we found. So outside of research into this palliative intent treatment and more research into the disaggregated Hispanic subgroups, I do think that there are a couple of strategies that we could highlight that may kind of help focus on these issues. And one is a greater focus on culturally sensitive approaches to end-of-life care. And like I mentioned earlier, also focusing on including caregivers, family members, and communities in healthcare decision making, and also in just helping to understand why palliative care is important and understanding what might be some of the drivers and why palliative care may not be taken up in as much as we would like it to be. Another thing would just be focusing a lot on patient engagement in some of these programs to get patients involved in these treatment plans. And I think that's also very important. So just being very hands-on when it comes to that. In our study, we focus a lot on what might be some of the drivers for these disparities. And while I can't point to just one thing, there are a lot of different factors and a variety of different mechanisms that might be at play that might cause some of these disparities. And so focusing on those drivers is just as equally important. And, there's a lot of different drivers. So it could be religion or language or cultural norms or preferences, end of life care preferences, I don't know, immigration status. Cost and financial toxicity. There's a lot of different things that might be going into this. And so that's why research is so important. Just focusing on each population and what might be the result of the different disparities so that way those different drivers can be addressed. And so and to answer your question about whether these strategies are the same for each cancer type, I do think that a holistic approach is necessary. While I do think that varying the different strategies may be helpful for different cancer types, at the end of the day, the disparities we saw are present among all the different cancer types that we research, so breast, lung, and prostate cancer. And so it's just clear that a holistic approach is necessary. In terms of differences between specific populations, I will say that that one probably would need to be more honed in for the specific population. I think that each population has their own culture, they have differences in language, differences in the way that they kind of hold themselves. And so, really digging down and seeing what those differences are between specific populations so that way interventions can be tailored to them and be most helpful for them. I think that that is a good approach as well. The main kind of point that I think this study is trying to show is that there are disparities, and like Dr. D has mentioned, there Hispanic subgroups, along with a lot of other race and ethnicities that we don't focus on in this study, are heterogeneous, and so it's important to just look at each patient and understand that each patient is kind of dealing with a different thing, and so really having a patient-centric view of healthcare is important. And that's kind of what we're really getting at is just the patient is what's at the crux of everything. And so I think that's just the main point that we should come out of this with.
I think the other piece is that such work should fuel qualitative studies as well. We hope that this effort can serve as a jumping point for work that goes into the communities and actually asks patients, like what are the barriers that you face? What are things that might be unique to Mexican populations? What are things that have, supported, Puerto Rican populations, for example, who are oftentimes in multiple cancer types or groups that seem to have more access, right? What are mediating those differences, and how can we then implement what works in groups that have access for groups that don't? This is not to kind of binarize everything, but we are seeing a pretty strong signal here, right? Like what are barriers that, for example, Mexican populations are experiencing that Cuban populations or Puerto Rican populations aren't seeing? What can we learn from the experience of Dominican patients? And take that to, I think I froze. And take that to the rest of the population, right? Are these issues of immigration? Are these issues of language? Are these issues of socioeconomic status? What are the social determinants that are underlying all of these? We aim to adjust for some of the factors like zip code level, socioeconomic status, and educational attainment in the study, but these are imperfect adjusters for things that are really kind of complicated and interlinked. And I think marrying a quantitative approach like we present with qualitative lines of questioning will really help to serve the community.
I think in terms of next steps, this is something that we've kind of touched on, but I think focusing on some of those more qualitative research metrics and partnering that with some of the results that we found in our study is important. I think that's just the main kind of next step is really diving down and seeing what might be the drivers and asking patients and going into communities and learning from them. I think that that's the best next step for the future, in addition to kind of mediating whatever disparities are present through some of the interventions that we may have mentioned, along with others that we might not have. I do think that this study kind of serves as a jumping off point for policy and like Dr. D has mentioned, a lot of data driven policy initiatives, which is a lot of what I'm interested in. So a lot of my interests kind of go dive into health policy and understanding how policy and healthcare fields intersect. And so this summer I have the opportunity to intern at the Greater New York Hospital Association and learn more about how federal and state policy impact healthcare and how healthcare can kind of impact federal and state policy and understanding what the relationship is there. And so this study has been an amazing experience for me to kind of learn and see how research can kind of drive and inform policy and make change for populations that may be experiencing disparities, especially as we focus here on palliative intent treatment. So that's been an amazing experience for me, especially as a student hoping to kind of get into health policy in the future and make change that way.